Now we will go into neurosciences. As I began my class, I told you that in neuro, what you need to know is how to manage the blood pressure of the brain, how to interpret the investigations of the brain, how to assess the requirement of newer modalities, like when do you need a transcranial Doppler, when do you need a microdialysis, when do you need an external ventricular drain. I mean, when is the point that you need to know? When and what? So the timing is important, both in heart and in brain. Overall, in critical care, timing is important. But timing to what? We as intensivists are required to understand the whole physiology of all the organ systems, and we are needed to be in a position to tell whoever is treating that, boss, this is wrong, this is somewhere correct, we need to do. We need to set the things right because this patient is deteriorating. The intensivist comes into the picture when the patient is deteriorating. The intensivist never comes into the picture when the patient is getting better. So we should be very, very clear on to how to interpret the deteriorating patient. Very important. Is that clear?
Yes,
So
sir.
whenever you are studying any subject of critical care, you should keep in mind that the patient is deteriorating. And if you don't act, nobody is going to act. So let us begin with the first question, that a 62-year-old hypertensive male develops a right MCA stroke. Which of the following best describes the autoregulatory pattern in this patient? Number one, cerebral blood flow is independent of the systemic blood pressure between MAP of 50 to 150. Second, autoregulation is impaired in the infarcted region, but it is intact elsewhere. Third, autoregulation is completely lost throughout the brain once infarction sets in. Fourth, cerebral blood flow increases linearly with increasing mean arterial pressure.
D.
B. I take B.
B for B for Bombay ball.
Yeah.
So the correct answer is B. That is, autoregulation is impaired only in the infarcted region, and it is absolutely intact in the surrounding brain. Now, the concept of autoregulation means the brain's ability to maintain a constant cerebral blood flow despite the fluctuations in mean arterial pressure, usually between 50 to 150 millimeters of mercury in healthy people. Now, this patient who has a stroke means that this patient's autoregulatory response in the infarcted region will be disrupted, but it remains intact in the non-infarcted areas. That is why it is so important to let the blood pressure go up in a patient of ischemic stroke. So, because if the blood pressure goes up, only then we can maintain the circulation and perfusion of the infarcted region.
Sir.
The penumbra.
Yeah. Otherwise, if we control the blood pressure, we bring it down just by seeing the blood pressure on the monitor or by checking it, we risk increasing the umbra. We risk increasing the size of the infarction. Why? Because the blood pressure control, the autoregulation is lost in that part of the brain, and we will have to control it. And we will let the leash loose. We will let the blood pressure go up till 220. Let it go up so that the perfusion through the affected brain is maintained. Is that clear?
Yeah.
So if there is an ischemic core, if the blood pressure drops too much or by our medications, the ischemic core will increase in size. Okay. So why the first option is wrong, that cerebral blood flow is independent of systemic blood pressure between MAP 50 to 150? This is the definition of normal
Normal
cerebral
brain.
autoregulation.
Yeah.
It is not a normal brain in this case, it is an infarcted brain. As far as someone was saying the answer D. Now, the cerebral blood flow increases linearly with increasing MAP. That happens only if the autoregulation is completely
It's
lost.
lost.
For example, diffuse axonal injury. For example, severe brain injury, where there is no correlation between the blood pressure and the autoregulation. So, whenever the autoregulation thing is completely lost, only then the cerebral blood flow increases linearly. The more MAP you increase, the more cerebral perfusion occurs. That happens only in cases of,
Severe brain injury.
yeah. As far as the infarction is concerned, the linear uh, this the linear increase in cerebral blood flow with increasing MAP occurs only in case of infarcted region, infarcted territory. Great. Now, second question is, a 45-year-old male with traumatic brain injury has a GCS of only 7. You decide to intubate this patient. What is the cutoff for intubation in a poor GCS patient?
GCS of 8.
GCS of
8.
8. So the patient has now deteriorated. The GCS has come down to 7. I told you, when deterioration happens, only then intensivist comes. So this patient GCS is 7. The decision has been made to intubate. What induction agent will be the best choice?
Propofol. It's propofol.
Propofol.
So as
As
far
long
as
as the blood pressure is
yeah,
good.
so what will you now you answered yourself. So what will be the answer? The GCS is low, the traumatic brain injury is there. The chances are that this patient will require etomidate, because the traumatic brain injury requires a rapid sequence induction. Propofol by no means is a rapid sequence inducer. You need something which is a fast acting and also does not cause hypotension. To be able to intubate with propofol in rapid sequence, you will need very high doses of propofol, and that will lead to hypotension. As far as etomidate is concerned, you can use as much dose as you want without causing hypotension. And etomidate will lead to sedation within 30 seconds, but not with propofol. To achieve 30-second RSI with propofol, you need very high doses again. Is that clear?
Yeah.
So, in a hemodynamically stable patient where you have enough time, you can use propofol. But in a patient in whom GCS is only 7 and you need rapid sequence induction and intubation, you will need some agent which acts very fast. You can give whichever dose you want, because there are two problems here. You want very deep patient, but you do not want hypotension. You understand when I say very deep patient? Deep means you don't want any rise in blood pressure. You don't want any complications related to intubation related injuries to the brain. You want the patient to be in deep state. You want to give good dose, but you don't want hypotension. So the only answer here should be etomidate. Okay. Now comes status epilepticus. Very important topic for EDIC exams. A 38-year-old female is in generalized convulsive status epilepticus despite receiving 2 doses of IV lorazepam. What is the next step?
IV phenytoin.
So the answer will be IV phenytoin, because that is the drug in the algorithm that you need to give. IV phenytoin. Although nowadays usually injection Levipil, that is levetiracetam, is being used, but the algorithm based approach is: number one is benzodiazepines, number two is the phenytoin, which is the second, or fosphenytoin, both of them can be used, which is the second line drug, or third line drugs are IV valproate, and fourth is basically IV levetiracetam. In some guidelines, phenytoin is also used as the first drug of choice. Why? Because number one, it is effective for long-term seizure suppression. It has a long half-life. So as far as IV midazolam is concerned, you've already given midazolam and you don't want an infusion right away. Second is IV sodium valproate is a second line drug only after phenytoin has been used. As far as levetiracetam is concerned, again, it is a second line option, but not superior to phenytoin. Is that clear?
Yeah.
So if I have to draw a chart for you, then the first line is lorazepam, or if there is no IV line, then intramuscular midazolam or perrectal diazepam. This is the first line. Second line is IV phenytoin. Third
Oh,
line is
levetiracetam.
IV, yeah, phenytoin, and the alternatives are levetiracetam and valproate. They are placed at second line only. The third line is IV midazolam or propofol infusion. These are now infusions, but this requires patient to be ideally intubated. If somebody has a super refractory, that is, three drugs have been given, super refractory, um, what do you call super refractory status epilepticus, then IV ketamine or IV pentobarbital, then these are the drugs that can be considered. Is that clear? This is the chart. So first line drugs are lorazepam. Second is IV phenytoin. As an alternative to phenytoin, if phenytoin cannot be used due to certain circumstances, then valproate or levetiracetam. Third line drugs are the infusions, midazolam, propofol. And fourth line, when the super refractory is there, that is where you consider intravenous ketamine or IV pentobarbital. And the aim is to achieve a coma. It is a straight line on the EEG. All right. Which of the following is not consistent with brain death? Absent brainstem reflexes, persistent coma with known cause, spinal reflex movements, or decerebrate posturing.
Decerebrate
Spinal
posturing.
reflex. Spinal reflex movements.
So decerebrate posturing is the answer
Uh,
that that defines that the patient has some sort of brain stem which is still working. So the brainstem reflexes, the absence of them, persistent coma. So basically, and spinal reflex. So basically, what you understand from brain death is that there is irreversible cessation of all cerebral and brainstem function. So spine is mentioned here. Spine may be intact, spine may be not intact. That is not considered in the definition of brain death. So the brainstem reflexes should be completely absent. Spinal reflex movements persisting is no it is not considered anywhere in brain death. So it can be present, it can be absent. Death is not defining the brain death. The patient needs to have absent brain reflexes, brainstem reflexes very clear. Their persistent coma with known cause, for example, traumatic brain injury, there is no structural brain differentiation anywhere, massive stroke, hypoxic brain injury, where you have structural loss of the brain clearly, then presence of spinal reflexes, that doesn't tell us anything. Decerebrate posturing means that there is some brainstem pathway still working. Okay, maybe vestibulospinal, maybe red nucleus, anything. Brain death patient should have no brainstem involvement. Is that clear? So the answer is decerebrate posturing. If the decerebrate posturing is present, this is not brain death. A 50-year-old man with large intracerebral hemorrhage has an intracerebral pressure of 30. Which of the following is the first line therapy in such a patient? Mannitol, hypertonic saline, mannitol, decompressive craniotomy, or therapeutic hypothermia.
Decompressive craniotomy.
Anyone with a different idea? Or should we go in with this answer? So this patient has an intracerebral hemorrhage with an elevated ICP of 30. So the number one in all the guidelines now is 3% saline, that is hypertonic. You can use 3% saline, or in certain advanced countries, even 23.4% saline is also available. That can be given as a 30 ml bolus over 10 minutes. So the first step is, because the patient needs a decompressive craniectomy, but it will need some time to prepare the surgery for shifting the patient, but the patient has a risk of getting coned during that time. So immediately when such a large increase in ICP is there, you have to do something which is urgent and immediate. So elevating the bed end to 30 degrees, 30-degree head end elevation, ventilating the patients, hyperventilating, administering IV saline or mannitol. This is the guidelines now. So saline is preferred, mannitol is if no hypovolemia risk. Then sedating the patient, and then if refractory, then take up the patient for decompressive craniotomy and do hypothermia. Is that clear? If in
Let me
EDIC
just
exam,
ask a question, sir.
yeah.
Now, since the question did not specify that the patient is about to cone, will there still be a place for hyperventilation? There is no
Uh,
tentorial herniation.
yeah. So when you see that they have mentioned an ICP of 30, that means this patient will need not emergent, urgent, needs right now management. Are you
Okay.
getting my point? You need to
Yeah.
do something right now. Number
Okay.
one is, if you just go and dwell into the case that patient has a large intracerebral hemorrhage and you have put in an ICP monitor. So your main aim is to monitor the ICP. Whenever it goes beyond 16, the bells start ringing. So the moment it goes above 16, you start thinking about potential management strategies as to how to decrease ICP. Now the problem is that the patient has an ICP of 30. Now is not the time to think much. You have to act very fast, because
Yeah.
after 30, what will happen? The patient will cone.
Yeah.
So they need not mention that the patient is coning. This is where I started when I started my lecture today. You are called in when the patient deteriorates. This patient has deteriorated. They will not tell you that this patient is coning. They have
Yeah.
just told you that the ICP is 30. You have to decide, is he going to cone? Will he cone in the next 30 minutes? Will he die? So if you see that at 30 intracerebral pressure, in critical care, it is very wisely said, if you think this needs to be done, it
Do it.
needs to be done. As clear.
Yeah. Thank you, sir.
So at an ICP of 30, what do you think can happen? What do you think can go wrong?
He's a coning, sir.
Yeah. So at ICP of 30, I fear the patient will cone. So I will do everything in my capacity to not let the patient to cone. As simple. I will run in with 3% saline. If I don't have it, I'll run in with mannitol. If I've still done it and ICP starts coming down, let us say comes down to 24, I give another bolus of mannitol or 3% saline or whatever I have to not let the patient cone. That's it. If
All right.
what and in the meanwhile, also inform the surgical team that be ready with your OT and everything. I have intubated the patient because at an ICP of 30, if you are going to intubate the patient at that particular time, it will cone the patient again. So you have to bring it down a little, give a Tomidate, knock out the patient, intubate him, and then take him to the operation theater. This is the series that will happen. This is the sequence. Is that clear?
Yes.
So that is why that after giving an exam of EDIC, you go from being a resident to a consultant directly. Because they presume that now if you have cleared EDIC, you have sharpened your mind and brain and reflexes, everything. Now you can take decision on your own. Okay.
Yes, sir.
Next question is, a 45-year-old woman with non-traumatic SAH is at risk of vasospasm. Which of the following is recommended for prevention? Is it magnesium? Is it nimodipine? Is it steroids? Or is it hypertonic saline?
Nimodipine.
Earlier, yeah, nimodipine is the answer. Earlier, there used to be 3H therapy. Do you know that?
What, sir?
Hypervolemia,
Okay.
hypertension. So that was the triple H therapy in cases of cerebral SAH to prevent the patients from developing this vasospasm. But now it is changed. Now it is to isovolemia. You don't hypervolemic. You don't give extra fluids to these patients, and now it is abolished. But then I just thought of when I was a resident, it used to be hypertension, hypervolemia, hemodilution. So these were the three H's for preventing the patient to go into vasospasm. Nowadays, it is not taught that way. Nowadays, it is just maintain normal normotension and isovolemia. So the triple H, somebody can ask you, I'm just telling you in reference. So triple H therapy was given to treat the cerebral vasospasm. So basically, it was number one H was hypertension that was induced. That means induced. That means you need to give these vasopressors like norepinephrine, dopamine, phenylephrine to keep the BP close to 140 to 160 millimeters of mercury. Second was used to be hypervolemia. So you expand the intracerebral and intravascular volume to keep the cerebral blood flow going. So the CVP target used to be around 10 centimeters. And the third used to be hemodilution. So we used to dilute the blood, give excessive water. Nowadays, it is said that you maintain euvolemia, you don't hyperventilate. It is not used nowadays. The current perspective has changed. It is triple H therapy is no longer used. Just as a historical evidence, it is used. So now Nowadays, it is not used. So now basically it is uh, euvolemia. It is basically just maintaining the blood pressure in the normal range. It is not there. Modern management, basically it is to continue using, uh, number one is to maintain. It is a very very logical situation. I'll tell you what it is. So nowadays it is used nimodipine. Nowadays it is to use nimodipine. It was not earlier. Earlier to they used to say give vasopressors. Now it is nimodipine. Number two is euvolemia, and number three nowadays is endovascular therapy. And endovascular therapy, they do balloon angioplasty. They open up the blood vessel and they give intraarterial verapamil, nicorandil, milrinone, nicardipine, so much, and then maintaining normothermia and normoglycemia and monitoring. This is something addition which is monitoring transcranial Doppler. Okay. Although induced hypertension is still used selectively, where you do a CT angiogram of the brain vessels and you see that the blood flow is tremendously decreased, then you increase the systemic blood pressure so as to increase the blood flow through the autoregulatory pathways. Is that clear?
Yeah.
Next question: which are the following findings in a patient of Guillain-Barré syndrome indicates a need for intubation? Bilateral facial weakness, absent
Absent
reflexes,
reflexes.
or forced vital capacity less than 20 mils per kg, or CSF picture of albuminocytological dissociation. So the answer here is basically the reduced FVC. So what happens is that you want to intubate the patient who is at a risk of retaining carbon dioxide, going into CO2 narcosis, and going into respiratory metabolic acidosis or resultant hypoxia. Otherwise, you don't want to intubate such a patient. Absent reflexes, these patients have lost reflexes already. They come to the hospital with no reflexes. But uh, what is the best bedside test to check the functional vital forced vital capacity of a patient? So
It's
you single breath count. You tell them to count from 1 to 100 in a single breath, and you also start counting in front of them. So what happens is these patients, they usually get intubated when their single breath count is less than 20. So they just go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 4. Then this is the time when you should be intubating such a patient. If they can do 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 20, 23, 24, 25, 26, 27, 28, 29, 30. That means their functional, their forced vital capacity is intact. They will not go into hypoxia or hypercarbia. They will not go into respiratory acidosis. They will not die because of respiratory compromise. As simple as that. So you intubate these patients only when you see that their functional or forced vital capacity is going down. Is that okay?
yeah.
That is the criteria is same for myasthenia gravis also. You don't intubate all the patients of myasthenic crisis unless their vital capacity is below 20 mils per kg. Is that okay?
Yeah.
A 60-year-old woman with myasthenia gravis presents with respiratory distress. Which of the following is contraindicated? IV immunoglobulin, plasma exchange, IV steroids, or succinylcholine?
Succinylcholine.
Yeah. Why?
It can worsen the muscle weakness.
So,
Upregulation of receptor.
yeah. So basically, what happens is the acetylcholine, um, what is the problem with myasthenia gravis? There is an antibody which is sitting there, and it is anti-acetylcholine receptor antibody. And what
Yeah.
kind of an antibody is it? Is it a stimulatory or an inhibitory?
I think it destroys the receptors so that the receptor population is markedly reduced.
So basically, they block the uh, the receptor, the acetylcholine receptor, in an inhibitory manner. So what happens is the acetylcholine cannot bind to that receptor, and succinylcholine also does the same job like the antibody. So what is happening here is, if we give succinylcholine, it will also act in the same manner as the antibody which causes myasthenia gravis. So there are chances of prolonged paralysis with succinylcholine, that if you intubate such a patient using succinylcholine, there are fair amount of chances that they do not come out of succinylcholine for 5-7 days at a stretch. They remain paralyzed for so long. That also is the case of an unfortunate man who has myasthenia gravis and gets bitten by a cobra snake. That happens. The neurotoxin venom also does the same job to that patient. Is that clear?
Yeah.
A patient presents with acute ischemic stroke 2 hours after symptom onset. What is the next best step? So what is the thrombolytic window for stroke patients?
4.5 hours.
So what will you do in this patient? The patient has come to you within 2 hours.
Well, I
So
think it's to give aspirin first before.
So acute ischemic stroke 2 hours
Okay.
after symptom onset. So still 4.5 hours is not passed. What will you do? You will thrombolize this patient. And which is the drug which is approved to thrombolize? IV-TPA. That is the first answer.
Okay.
Do you have any doubt?
I thought, okay. Anyway, since the diagnosis has been made that is ischemic, usually
Yeah.
usually before the diagnosis is made, we are taught that the patient should be given about 300 milligram of aspirin,
Yes. Yeah.
while waiting.
So now the diagnosis is made. Acute ischemic stroke. So basically, the examiner only wants to know whether you know that 4.5 hours is the cutoff time for the thrombolysis. So that is why they specifically mentioned that a
2
patient
hours
presents with an acute ischemic stroke
window.
2 hours after symptom onset. Of course, you will give aspirin, but what is the definitive therapy in such a patient? It is thrombolysis.
Yeah.
And what happens if the patient comes to you after 6 hours?
Just admit in ICU and
So you admit and
that's
take
when
up the
you continue with aspirin and all other anti-ischemics,
no,
including
no, no. Now the recommendations are that you admit the patient and do a DSA, digital subtraction angiography. And if in the digital subtraction angiography you see that the penumbra is large and the umbra is small, and there are collaterals present, then you should go in and perform an endovascular thrombectomy.
okay.
That you can do up to 24 hours.
Okay.
So up to 4.5 hours, it is thrombolysis. From 4.5 to 6 hours, there is a gray area. There are no solid concrete guidelines. After 6 hours to 24 hours, if the life is precious, it's somebody like president, prime minister of some country, and you can do a DSA, and you find that there are collaterals present on the angiogram, and you can see the thrombus, you can actually go in and take the thrombus out and give them a fair chance of survival. That is possible that you can do. Okay, so that's called endovascular thrombectomy. You should go through those guidelines as well. You should just fill in that what are the guidelines for endovascular thrombectomy in ischemic stroke. You will get the data.
Okay, sir.
Which of the following is the gold standard for monitoring intracranial pressure? Is it an epidural probe? Is it a
No.
subdural catheter? Is it an intraventricular catheter? Or is it a
Yeah.
jugular venous oximetry?
Intraventricular catheter
So the answer is intraventricular catheter. And what is the normal range of ICP?
is 5 to 15.
Yeah. So whenever it goes beyond 16, it should ring bells. That
Yeah.
means the patient has elevated ICP. Which of the following CSF findings is most consistent with bacterial meningitis? Mind you, if you are going for EDIC exam and you have not gone through the CSF findings for number one, bacterial pyogenic meningitis, number two, viral meningitis, number three, fungal meningitis, and number four, what do you say that? Yeah, fungus and TB, tuberculosis meningitis. These four CSF findings, they should be at your tips. Okay.
Okay,
So,
sir.
which of the following CSF findings is most consistent with bacterial meningitis? So, in bacterial
D.
meningitis, the total
D.
WBC count is very high, more
Yeah.
than 1,000, and glucose is very low, that is less than 40. So, if the total count is not very high and the glucose is very low, what is the diagnosis then? If the WBC count is less, let us say 200, and glucose is only 20, and
Could
it
that
is
be viral?
I'll repeat. In viral, the glucose will not go down so much. So
Okay.
WBCs around 200, glucose 20, WBCs lymphocyte predominant. This is
Look like
TB,
Oh, TB. TB.
TB, TB meningitis. WBCs around 100, glucose around 100, WBCs mainly lymphocytes. What is this?
Viral.
Why? Okay. Which of the following clinical features is most suggestive of a metabolic coma rather than a structural brain injury? So, out of the options, which of the following favors a presence of metabolic cause of encephalopathy rather than a structural brain injury? So, basically, this topic comes from assessment of the coma. Asymmetrical pupils. Usually, asymmetrical pupils tell us
Is
about some
structural.
structural disease.
Yeah.
Preserved pupillary reflexes, yes. For
Yes.
yes. Hemiparesis, yes. Hemiparesis usually is due to, unless it is a hemiplegic migraine, but presence of hemiparesis tells us about territorial involvement of a cerebral compartment. Decerebrate posturing, obviously there is a problem with the brain which is injured. So metabolic comas, they usually have intact brainstem reflexes, while structural lesions can cause focal deficit. So the only answer here is preserved pupillary reflexes. Okay. Now coming to some spinal cord injury and spinal cord related syndromes. Which of the following is characteristic of anterior spinal artery syndrome? It is a one of the hot favorite questions of the EDIC examiners. Anterior spinal cord injury.
Loss of pain and temperature sensation with preserved proprioception.
So the proprioception is preserved because it is a dorsal column. It
Yeah.
is posterior column. Uh, uh,
Tract.
Posterior column. What is the word? It is the posterior column parameter. So, so the anterior column, anterior spinal artery syndrome basically occurs due to infarction or the ischemia of the anterior spinal artery, providing the anterior two-thirds of the spinal cord. So what gets affected is, uh,
Then the temperature.
so basically
So
the
the
corticospinal
anterior,
tracts are
yeah,
involved.
anterior and lateral.
Yes,
Yeah,
and the
okay.
spinothalamic tracts, they are
Yeah.
involved. So, because of the corticospinal tracts involved, the patient will have UMN below lesion and LMN at the lesion level. And because the spinothalamic going from below upwards, so pain and temperature will be involved. The dorsal column is totally spared because it is the property of dorsal column to carry proprioception and vibration. Okay,
Yeah.
great. Which intervention is most effective in preventing ICU delirium?
Early mobilizations.
Very good. So, early mobilization, keeping the patient active, keeping them involved, maintaining good sleep hygiene, and avoiding unnecessary sedation will lead to preventing ICU delirium. Very good. A Parkinson's patient is managed in ICU, but he develops severe rigidity. What has gone wrong? Is it sepsis? It is overdose? Is it any neuroleptic malignant syndrome or myasthenia crisis? Very good question.
Neuroleptic malignant syndrome.
Why and how?
I think it's one of the adverse effects of some of the anti-Parkinsonian medications.
Okay. So basically, what happens is in this case, neuroleptic malignant syndrome does not happen because we have given something, but it is because we have not given something. So abrupt withdrawal, oh sorry, again, the eraser is working, the pen is not. Abrupt withdrawal of Parkinson medications, like the dopaminergic ones, it will lead to neuroleptic malignant syndrome. Also, exposure to anti-dopaminergic drugs like metoclopramide or antipsychotics, as you said. So they are D2 blockers, and dopamine blockage is the problem here. So what will happen? What are the diagnostic criteria for neuroleptic malignant syndrome? Number one is the patient becomes very rigid. So number one is severe rigidity, like already told in this. Then autonomic instability. The blood pressure will go from 200 to just 50 over a matter of seconds. Autonomic instability, confusion, and altered mental status. And fourth, but not the least, is elevated CPK and presence of myoglobin in the urine, myoglobinuria. So abrupt withdrawal of levodopa, carbidopa, even missing a few doses can lead to neuroleptic malignant syndrome, even at home also, not necessary in the hospital. And certain drugs being administered, like these metoclopramide, some antipsychotics, haloperidol, sometimes Serenase is given, wrongly diagnosed that these patients have delirium. So they give haloperidol and the patient lands up into neuroleptic malignant syndrome. A 34-year-old presents with sudden onset paraparesis and a sensory level at T6. MRI is normal. What is the most likely diagnosis? Sudden onset paraparesis with sensory level at T6. Quick answer is
Functional disorder or spinal cord infection. Spinal cord infection.
yes. I told you, no, there will be a sensory level at a particular point. So sudden onset paraparesis with this is clear. Clearly, the answer is spinal cord infarction, and the cause may be any, but this patient has spinal cord infarction. So
like blood
needs
clots.
this this needs to be addressed immediately, and these patients who have spinal cord infarction, they should be worked up immediately. In a young patient of just 35 years age, this patient should be worked up extensively for the presence of plaques, for dyslipidemia, familial dyslipidemia, homocystinemia, and all those things immediately. Or aortic dissection is a very, very important cause in young people. uh, Vasculitis, etc., they should also be ruled out. A young woman presents with headache, seizures, and papilledema. MRI shows an empty delta sign. Very important question. Empty delta sign, you must remember always. So, MRI shows an empty delta sign. So, what is the most appropriate treatment?
Wow.
So, this patient, empty delta sign, has cerebral venous sinus thrombosis. Okay.
Okay, so it's heparin.
So, the treatment will be heparin. Which of the following is a hallmark feature of amyotrophic lateral sclerosis? Purely sensory symptoms, upper and lower motor neuron signs, rapidly reversible paralysis, or involvement of extraocular muscles.
Reversible paralysis.
So, upper and lower motor, presence of upper and lower motor neuron signs in the same patient is a very, very strong indicator for amyotrophic lateral sclerosis. Very, very important. Very, very important. These patients, they have both the signs present, and this helps in establishing the diagnosis, because usually the patients have either upper motor neuron lesion type signs or the lower motor neuron like signs, but hallmark of this ALS is presence of both upper motor and lower motor neuron. So the upper motor neuron signs that are usually present are hyperreflexia. These patients are spastic, and there are certain reflexes like Babinski is positive, the Hoffman is positive. At the same time, because of the anterior horn cell degeneration, these patients have atrophy of the muscles, fasciculations are there, flaccid weakness is there, and at the same time, these patients have hyperreflexia, but the patients are having flaccid weakness. This is amazing. Presence of both type of signs in the same patient, presence of fasciculations with hyperreflexia, you should always think of this patient as having amyotrophic lateral sclerosis. Is that okay? Very
Yeah.
important. Very important. So upper and lower motor neuron signs being present. Which of the following differentiates Miller-Fisher syndrome from classical Guillain-Barré? Areflexia, ascending paralysis, ophthalmoplegia, or high CSF protein? What is the answer?
Areflexia.
So ophthalmoplegia. See, areflexia will be present in both Guillain-Barré and Miller-Fisher. Ophthalmoplegia also can occur in Guillain-Barré if you are thinking on those lines, yes. But then ophthalmoplegia is more in favor with Miller-Fisher variant. So Miller-Fisher variant is characterized. So that is why you start thinking that this is not GBS when ophthalmoplegia is present. Maybe it is a variant of GBS. That is when you start looking for other causes. So in Guillain-Barré, actually ophthalmoplegia will not be present. If present, this is Miller-Fisher variant. Is that clear?
Yeah.
So the answer is ophthalmoplegia. Miller-Fisher variant has ophthalmoplegia, ataxia, and areflexia. So areflexia is common. Ascending paralysis is also common. But ophthalmoplegia, presence of ophthalmoplegia is typically seen in Miller-Fisher variant. Which of the following is the strongest predictor of poor outcome in traumatic brain injury? So as I told you, in traumatic brain injury, the whole brain, it fails on auto regulation. So what happens is the sympathetic system tries to elevate the blood pressure to maintain the blood flow in the brain. But imagine if somebody has a traumatic brain injury and the patient has a hypotension. the BP is low, then these people are at a very, very poor prognostic indicator. Okay. So out of the options given, hypotension is the worst predictor of outcome in case of traumatic brain injury. GCS less than 8, unilateral fixed pupil, CT showing contusion, all these patients can make out. But hypotension patient, they do not survive because there is a progressive loss of brain function. Okay.
Okay.
Which of the following is not a component of Horner syndrome? It's an easy one. Ptosis, meiosis, and hydrosis. So ophthalmoplegia is not a Horner syndrome, you know, na? Yeah.
Ophthalmoplegia.
Yes, ophthalmoplegia will not be there. It is ptosis, meiosis, and hydrosis. Okay. Okay. Which of the following is most effective management of subarachnoid hemorrhage? That is the question precisely. Which of the following is the most effective in preventing rebleeding after subarachnoid hemorrhage? Obviously, the patient comes to the
Clipping and
hospital.
coiling.
Yeah, it's surgical clipping. The patient has come to the hospital with a headache and you've diagnosed the patient as having a SAH and you have identified the bleeding aneurysm. Now, what is the best way to stop rebleeding? The answer is clip the damn thing. Just that's the treatment for. And later on, if vasospasm occurs, then you have to go back to that management protocol that I told you. Maintaining isovolemia, maintaining good blood pressure, nimodipine, and these things. And keep doing transcranial Doppler. And in case nothing works, then go for endovascular dilatation, balloon dilatation. Okay. So that is for the neuro part. I've tried to cover almost everything in the neuro, but then there might be something which I've missed. So do let us know. But then this is in crux what is the most important topics for cardiology and neurology as far as EDIC exam is. All right. Okay, candidates.
Thank you, sir.
Have a good weekend. I hope this class was informative to you.
Yes.
Thank you very much.
Very,
Sir,
Thank you.
actually, very
We are very
nice
grateful.
class, sir. I have a question. Very nice class. Sir, do you have respiratory system class? Can you take? You are very nice explaining, sir.
Yeah, I can take respiratory. I can
Please,
take
sir.
it.
We request you because you are wonderful, sir.
Okay,
And
I will
again,
do.
the cardiology class, the repetition of the cardiac class again with
It's
full
okay.
coverage.
It's okay, cardio, but respi, if sir, you teach us, na, sir. Really, we are.
No, I
very
will
thankful.
take respi. No worries, no problem. I will take respi, but that will happen next Sunday then because I have time only on Sundays.
No
Can we
problem,
do
sir.
that?
It's
Yeah, yeah.
perfectly okay, sir.
Yeah. Okay, Sana, can we do that respiratory if the other teacher is not getting offended by it?
Yes, sir. Yes, sir.
I'm really, we are very thankful, sir. We want sir to do respiratory.
Okay, we will do.
Okay, thank you, sir. Thank you.
All
Sir.
right, thank you so much. For
Thank you, sir.
respiratory, I will have maybe 30-40 questions more because cardiology you can cover, but respiratory is the core intensive care thing.
Yes, sir. Sir, we want that, sir.
We will cover ARDS, we will cover all sort of respiratory syndromes, and
Yes, sir.
of course ventilatory management and arterial blood gases,
Yes, sir.
and pulmonary vascular diseases as well. So they are
Yes, sir.
very important as far as EDIC is concerned. So we'll take it, no worries.
Yeah, thank you, sir. Yeah.
All
Thank you
right.
very much, sir. Bye-bye.
Thank you.
Thank you, sir.